Hi, my name's Allison. I'm going to be your student physical therapist today. I'm going to be palpating some structures of your hip and your glute region. Is that going to be okay?
Yeah, it's fine.
Okay, I'll have you lay on your stomach for me. And then I'm going to have to move your shirt and your shorts out of the way a little bit. Would you prefer that I covered you so it's a little more modest, or are you okay?
I'm good.
Okay, I'm going to move this up a little bit then, and your shorts are just going to come down a couple inches. And the first structure I'm going to palpate is the PSIS. That's a prominent bony structure in the hip and back region. So first I'm going to find where those are with the palm of my hand and then come in with my fingertips. That's right about there. And this structure is important to palpate so that we can find the level of S2 as well as pelvic alignment and some ligament attachment points. So from there, if we move medially to the spinal column, it's going to be the level of S2. If we move up one vertebrae, that's going to be the level of S1. And then one more, it's a prominent spinous process, which is going to be the level of L5. So L5 is going to be an important structure to find so that we can find some other vertebrae up and down the spinal column, as well as latissimus dorsi attachment points and some other muscles. And then the next two structures I'm going to palpate, I'm going to be palpating more in your gluteal region. Is that okay with you?
Yeah.
Okay. So we've already found S2, so we're in the region of the sacrum. I'm going to use the sides of my hand to go down the lateral borders of that sacrum until I find the inferior angle where it starts to turn inward, which is going to be right about here. And that's an important structure for the sacrotuberous ligament, as well as the piriformis and some other muscles. And then the last structure in the prone position is going to be the ischial tuberosities. So for that one, I'm going to use the side of my hand to come into the gluteal fold and work my way superiorly until I find that bony infield, which is right there. And the ischial tuberosity is an important attachment point for all of your hamstrings, as well as the sacrotuberous ligament. First structure that I'm going to find is her C2 vertebrae. So I'm going to find the external occipital protuberance, and I'm going to drop just inferiorly to that, and I find a little bit of a hole, and that's where the spinous processes of C1 would be, but we can't quite feel that. And then if I drop one more inferiorly, I feel a pretty prominent spinous process. That's going to be the spinous process of C2. And that's an important structure to find because that's an insertion point or an origin point of the upper trapezius fibers, as well as a good spot to tell you what cervical vertebrae you're on, and to find the other cervical vertebrae that are inferior to that. And then if I move my fingers just a little bit laterally, I can feel the facet joints through some musculature. And those facet joints are where the cervical vertebrae articulate with one another superiorly and inferiorly, as well as giving you a place to, or a structure to palpate in order to find some of those transverse processes of the cervical vertebrae. I'm gonna give you back your pillow. Perfect. And then the next structure we're gonna palpate is gonna be your liver. Is it okay if I lift up your shirt?
Yeah.
Okay. So the liver is in the upper right quadrant of the abdomen. And so I'm gonna find the edge of her rib cage, which is right about here. And I'm gonna place my fingers right under there and palpate gently but pretty deeply under there in order to get a firm infield of that liver right there. And it's important to palpate the liver in order to find any potential non-musculoskeletal problems, as well as locating some other structures within the abdomen if you need to do that. I'm gonna pull this back down, and then the next thing I'm gonna do is palpate your hip bones. Is it okay if I bring your shorts down a little bit? Okay. So we have a pretty skinny patient, so pretty easy to see those ASIS, but I'm gonna come in with my palms to palpate those, and then once I'm pretty sure I'm on them, I'm gonna bring my fingertips in order to get a little more detail. And the ASIS is the attachment point for the inguinal ligament going between the two, as well as the sartorius. So to find the sartorius, I'm going to have you drag your heel up the side of your leg for me, and I can feel that contraction as it's running from the ASIS to the medial tibia. And then once you're up here, do you mind applying some pressure? Perfect. And we can palpate for the contraction of the adductor longus right there. You can put your leg back down for me. So the inguinal ligament, the sartorius, and the adductor longus muscle form the borders of the medial femoral triangle, and then the floor of that triangle is going to be the pectineus muscle if we palpate deeply in there. And then within the medial femoral triangle, we'll be able to palpate for the femoral artery, as well as the vein and the nerve. And then the last structure I'm going to palpate, I'm going to have you roll onto your side for me, if that's okay. And then I'm going to go ahead and support the patient, just making sure that she's safe. And I'm going to palpate for the greater trochanter. So I'm going to use the palm of my hand to find the lateralmost aspect of the hip, which is right about there. And then once I find it, I can use my finger pads to feel a little bit more detail. And the greater trochanter is the insertion site for the piriformis, as well as the gluteus medius and gluteus minimus. I'm going to be palpating some structures of your shoulder and like your ribs and your shoulder blade. Is it okay if you take your shirt off so I can better see those structures? If you're not comfortable, it's okay.
No, it's fine.
Okay. Perfect. So the first thing I'm going to palpate is the AC joint. So I'm going to follow her clavicle out and see where the clavicle meets up with the flat surface of the acromion process. Right there is going to be the AC joint. That's an important structure, so we can see a shoulder separation there, or we can look for some other musculoskeletal injuries there. And if we roll just inferiorly to there, we're going to find a little bit of a space. That'll be the subacromial space. If we have the patient abduct their arm or adduct their arm, we'll fall into a hole in abduction, and then it'll push me back out in adduction. That is a common spot of shoulder impingement, since some rotator cuff tendons run through there. And then if we dropped inferiorly and medially, we can palpate for the coracoid process, fairly deeply in there. It's usually tender to some patients. That is an attachment site for the coracobrachialis as well as the pec minor. And then I can use the palm of my hand to palpate in a circular motion to find the greater tuberosity of the humerus, which is going to be right about here, and I can find some more detail of that guy. That's going to help me find the lesser tuberosity, the bicipital groove, and some tendons for the rotator cuff for some attachment points. And then the next thing I'm going to palpate, we're going to move to her back and shoulder. So I'm going to palpate for her C7 and C6 spinous processes. So I'm going to find the most prominent bony structure on the back of her neck, and then put my finger up one more vertebrae, and I'm going to ask the patient to flex and extend their neck. And I can confirm that I'm on those vertebrae because that C6 spinous process will disappear when the patient goes into extension and reappears, so I can palpate it in flexion. Those are some important structures because the trapezius originates there, as well as that helps you find other vertebrae up and down the spinal column. And then moving laterally from there, we're going to palpate the patient's spine of the scapula, so we can feel it right here with the palm of our hand. That is an important structure, so we can differentiate between the infraspinous fossa and supraspinous fossa of the scapula, as well as an insertion point for the trapezius muscle. And then if we move more medially from there, we're going to be able to palpate the medial border of the scapula, and if we follow that all the way down, we can find the inferior angle right here. The inferior angle is going to help us find the insertion point for latissimus dorsi, as well as the teres major. And then from there, we can palpate some ribs. So if I run my hand along her neck, that first bony infeel I get to right there is going to be her first rib. And as that first rib comes anteriorly, it'll come and cross under the clavicle and help us find the manubrium, as well as be an attachment point for the anterior and middle scalenes. Then I'm going to have her move her arm out of the way a little. I'm going to find the inferior portion of what seems to be the rib cage right here. That's going to be rib 10, where it connects over to indirectly connect to the sternum. And then if I come down one more level, I'm going to palpate for that floating 11 rib, and then one more, a little more posterior, is going to be the 12th rib. That 12th rib is going to help us find the T12 vertebrae, as well as if the patient was in sideline, we can easily palpate the quadratus lumborum. And then coming down her arm even further, we're going to palpate for the medial and lateral epicondyles. So we're just going to use the palm of our hand to find those bony prominences. So I have the medial and the lateral. And that medial epicondyle is the attachment point for some wrist flexors, as well as if we roll posteriorly and laterally, we can palpate the ulnar nerve. And then the lateral epicondyle, if we roll medially, we can palpate the olecranium process, and it's the attachment point for the wrist extensors. If we come inferiorly to the lateral epicondyle, we can pinch the radial head and ask the patient to pronate and supinate their arm. And I can feel that radial head spin in my fingers right there. And that spins within the annular ligament. So we can palpate that for any issues, as well as that's a common site for a radial head dislocation, mostly in small children. And then moving more inferiorly, I'm going to palpate a wrist, but I'm going to do this one. So I'm going to palpate the scaphoid bone. Can you extend your fingers for me? And then I'm going to palpate down in that anatomical snuff box to find that bony infield, which is going to be the scaphoid bone. That's an important structure because when someone says they have a wrist fracture, they're usually referring to a scaphoid fracture, and it helps form that anatomical snuff box where we can find those tendons as well as the radial artery down in there. Then the last structure I'm going to palpate is the triquetrum bone. So I'm going to find the ulnar styloid process and roll off that distally and find the bony prominence right about there. And then I'm going to ask the patient to ulnar and radially deviate. And then I can confirm that I'm on that bone. It disappears in ulnar deviation and reappears when they're in radial deviation. And that is an important structure so we can locate some more of the carpal bones, as well as on the anterior side. It is a attachment point for the flexor retinaculum that forms the carpal tunnel. I'm going to first find this really palpable knee joint line where I can find some structures on the knee. So I'm going to be able to find the menisci as well as the collateral ligaments and the femoral condyles right here. And that's just going to be right off of the side of the patella. And then from there, if I come laterally, I'm going to be able to use the palm of my hand to palpate the head of the fibula right here. And then I can use my finger pads to feel some more detail. That is going to be the attachment point of the LCL as well as the biceps femoris. And then if we move even more distally to the ankle, the first thing I'm going to find is the talus, which is going to be directly in between the medial and lateral malleoli. And if I have the patient go into plantar flexion, it pops out, I can palpate it easier, and then dorsiflexion, it disappears. That is, like I said, between the malleoli, and it's a spot where I can find or locate all the other tarsal bones. And if I drop off the talus a little bit inferior, I will be on the navicular bone. And then I'm going to palpate for the most prominent bony structure on the medial side of the foot, which is right here. That's going to be the navicular tuberosity. That is the attachment point for the posterior tibialis, as well as that's considered the keystone for the longitudinal arch of the foot. And then if we move laterally over, we're going to find the fifth metatarsal. So that's going to be the most lateral metatarsal bone of the foot, and I can confirm that I'm on that by finding the styloid process. And that's the attachment point for fibularis brevis and the abductor digiti minimi. And then the last structure of the ankle, I'm going to find the ATFL, which is going to run between the lateral malleolus of the fibula and the talus. So I'm going to run my finger superior and inferior to find that ligamentous structure, which is right there. It feels kind of ropey. It's going to be taut in plantar flexion with a little bit of inversion, so I can feel it better there. And it's also a point where we can use to find some of the other ligaments of the ankle.